My presentation is on the rehabilitation of a female soccer player's distal radial fracture using cross-education, a case study. I'm going to present on a case study of using cross-education as a method of wrist rehabilitation on distal radial fracture in an Old Dominion Athletic Conference Division III female soccer player. The main objective of this, the whole idea behind it is cross-education and basically to see in as the method and to see the importance of it and to see if it will decrease rehabilitation time. So brief introduction. Wrist fractures are common and they represent about a quarter of all fractures in limbs, and 3/4 of wrist injuries are fractures to the distal radius and ulna. The wrist is made up of mainly 10 bones. 8 of them are the carpal bones, and then there's the radius and ulna. There's the mechanism of injury in a fracture, or an injury to the wrist, which can be a direct trauma or a fall on an outstretched hand. Then whenever there's a fall or a direct trauma, you can have a Colles fracture, a Smith fracture, or a Barton's fracture. And those are the 3 main type of distal radial fractures that you can see. So this is the picture of the right hand. Although my case study, it was her left, but I found the right hand. So this is the different bones, and I figured I'd show you guys all of them so then you know what they are. Okay, so the history of the athlete. She was a 19-year-old Old Dominion Athletic Conference Division III female soccer player who injured her left wrist during a soccer match. She came in 2 days after injury. She went to urgent care as soon as it happened. The ball was deflected off of a corner kick, hit her wrist, and she went down immediately. She went to the urgent care because there was immediate disfiguration and swelling of her wrist. Statement of the problem is the evaluation of the athlete and x-ray led to the diagnosis of a fracture to the distal radial bone. Because of the nature of the fracture, she was put in a cast for 8 weeks. So Bachel et al. Defines cross-education as training only one limb, resulting in a strength increase in the untrained limb. A recent review of the literature on this topic shows that strength in the untrained limb may increase up to 22%, with an average strength increase of about 8%. Rudy et al., he states that when movements are repetitively performed using one limb, the EMG activity is registered in the same muscle of the opposite limb and can show activity in there, which will also show strength gains. According to Watson et al., building on the arm immobilization models, there's new evidence that cross-education can benefit the recovery strength and mobility following wrist fractures, which is partially where I based some of my research / why I wanted to do this, because I found this information and thought, this is what I really want to do. So I was like, this is really cool. In a recent study, Magnus et al. Implemented a unilateral strength training of a non-fractured limb. And he did this in women over the age of 50 who suffered distal radial fractures, and found that the training group had significantly greater fractured limb hand grip strength and active range of motion strength than the control standard rehabilitation group, which goes along with the research that I had found. And it was also found that the long-term regimens of static passive stretching should induce strength gain in contralateral non-stretch limb. And all this information goes along with my case study, which I will get into. Okay, so my experimental design. It was single subject, and the subject agreed to do this, thank God, by informed consent. And it corresponds with the 3 phases of the healing process: the inflammatory response phase, the fibroblastic repair phase, and the maturation remodeling phase. In addition to those 3 phases, the athlete went through this 3 distinct phases that included the range of motion rehabilitation phase, an active range of motion and strength rehabilitation phase, and then a return to activity rehabilitation phase, which included functional movements as well. Within these 3 phases, I assessed the injury by measuring her active range of motion in week 1, week 2, week 4, and week 6. Limitations for this included the fact that sometimes we weren't able to meet on a regular basis due to time conflict, and also Thanksgiving break was during week 5, so we didn't meet for almost 3 days. But luckily, I was able to give her a take-home assignment, which was to do her stretching and strengthening exercises at home. So with the experimental design, the first thing that I did was, when she walked in after her cast was taken off, it was the next day, we measured her active range of motion with a goniometer, and with a Medgo tape measuring device, we also measured her forearm and her wrist, and measured both her uninjured and her injured side. By doing this, I got initial measurements and was able to figure out, where she was, and found out she was very, very limited in her range of motion. We started off with an ice bath to decrease the pain spasm cycle, and then also got into passive stretching in both the uninjured and injured side, where we held the stretch for 10 seconds and repeated this 20 times, both sides. And then we ended with ice. And we did this for about 2 weeks before we actually saw improvements enough to be able to move on to phase 2. So during the initial evaluation, after the cast was removed, the athlete presented with very limited range of motion, which I've already stated, and strengthened the involved wrist. The uninvolved wrist was within normal limits, and I've already said all that, actually. So this is a table comparing her right wrist, which was within normal limits, to her left wrist, and this was the initial measurements. And as you can see, she was very limited in flexion extension. Her pronation was normal, but that was because of the nature in which the cast had her wrist placed in. And then her supination and radial deviation and ulnar deviation were fairly limited as well. Her ulnar deviation was not quite as limited, but still limited. By the end of the 6 weeks, this was her final range of motion, which was comparable to that of her right wrist, which I was very excited about, because that means that, well, at least in my eyes, that means that the cross education did play a role and did help with finding her range of motion, like increasing that again. There was one point where her extension was limited at week 4 still, and so I implemented using some joint mobilization along with the cross education, because it was still about 10 degrees off, or 10 degrees limited. And by doing that, it actually moved it back, or it increased her range of motion, and her extension improved as well. Her strength Her strength increased as well. She moved from 1 pound to 2 pounds fairly quickly, along with 2 pounds to 3 pounds, and she ended at 3 pounds at the end of 6 weeks. And I tested her strength compared to her right wrist, and by the end of 6 weeks, she was 5 out of 5 in terms of against gravity and all of that as well. So do they have any questions?
So when you were all said and done with the rehab, was it in a normal time, or was it quicker, about the same as every other rehab?
Well, from what I found and from the research that I was looking at, it seems that most rehabs take 8 weeks to like could be 12 months or longer, and so it seems that it was quicker. But
Nice.
it seems that it was at least a little bit quicker. But I also found that in another book that it only takes 6 weeks, so it might have been right on track.
Normal to possibly quicker. That's
Yes.
cool.
Yes.
Can I ask a question for both of you since you're here? Is that okay?
I guess.
Okay.
I can't see you, so it's fine.
How
The athlete is not here.
how do you feel about your progress with her?
What do you mean?
Like, how do you feel like
I feel like I did a fantastic job.
like do you feel like
Obviously.
she is comfortable with like where she is today, like with her range of motion and stuff like that? I guess that's what I'm trying to
Yeah,
ask.
I mean, as we progressed, we talked like every time. I mean, I don't know what she would say, but every time that we met, I would ask her how she felt, what her pain level was. You know, whenever we were progressing, towards the end, you know, I had her get into a planking position. She was able to do that. She was able to throw a ball. She was able to catch a ball. She was able to do the functional stuff. The only thing that caused her issues was a push-up, and I think she was kind of a little bit afraid to do it because she was like, it's kind of painful, but I think it's, as she gets into the movement again, it'll like she'll become more used to it. If that makes sense.
Yeah, do you think you'd want to use it for like another, like if you had an opportunity to use this again, would you do it?
Yes. Yeah. Yes. Not yeah. Any other questions? Melissa.
Just out of curiosity, you mentioned about when you had the functional activities and her being uncomfortable with the push-ups in the beginning. Did you do any type of proprioceptive things like before you got to that functional activity?
I did not. That would be something that I should do in the future.
Should have not done.
Just went down the rabbit hole, I think.
So what kind of exercises was she doing when she was in the cast?
In the cast, she did, actually Chad had started her off on exercises before I started her off on exercises. But she did grip strength and she played with the putty as well.
She only did isometric stuff.
Okay.